Welcome to Health Live at Seniors Today. We are delighted to have here with us yet again Dr. Percy Chibber, who is going to be talking to us today about incontinence concerns for senior women and men. But before I invite him to speak, a little about him. Dr. Chibber is a senior consultant urologist with the HN Reliance and the Jaslok Hospitals, where he's also director of urology. He's also associated with the Breach Candy Hospitals, and he has been practicing in all aspects of urology for around 4 decades. His special interest being endourology, urological, laparoscopic robotic surgery, and renal transplantation. Dr. Chibber took his undergraduate medical education, that is the MBBS, at the Nair Hospital in Mumbai. He did his postgraduate in general surgery at the same hospital, standing first in the university, and was awarded 4 gold medals. He did his specialized training in urology at the University of Edinburgh, and with the world-renowned Professor G.D. Shishram, and also obtained his fellowship at the Royal College of, which is the FRCS. He returned to Mumbai and started his urological practice in 1981 and was soon appointed Honorary Assistant Professor of Urology at the Grant Medical College and the Sir J.J. Group of Hospitals, where he was later to hold the position of Professor and Head of Urology and Renal Transplantation between 1995 and 2007. We've had, in fact, quite a few doctors who have spoken about urology, who have in their profiles mentioned that they have been trained under Dr. Chibber. Dr. Chibber trained in the techniques of percutaneous renal surgery in the UK and US. Since 1983, he has developed and pioneered the techniques of percutaneous renal surgery and radiology in India. Has been one of the largest personal series of the procedure in the world. Since January 2000, he has been performing and training students in the technique of laparoscopic urology surgery. Welcome to Health Live at Seniors Today, Dr. Chibber. How are you?
Thank you. Very well. Thank you for the very generous introduction. A little excessive, I might add. Anyways, okay. So
over to you, Doctor. We've invited you to speak about incontinence for women as well as men.
Yes.
And what I'm going to do is, even as you switch on to the presentation, to all of you here, please mention, please go through the presentation, which will, of course, be also on our site on Monday evening onwards. But before that, if you have any questions, you could post them in the Q&A tab, mentioning your age and your gender. Given the nature of the topic that we are discussing, we will not reveal your name. We will all ask all questions anonymously, so you can feel free to express yourself in your questions. Over to you, Doctor.
Thank you very much. Good evening, everybody. Thank you very much, Pradyumn. This evening, I'm going to talk about incontinence in women and men, an increasingly common condition that involves all senior citizens and even younger people as well. What is the meaning of the word incontinence? The involuntary loss of urine, either by day or by night. It affects, we don't have very many statistics in India, but it involves about 17 million adults in the US. It's a major problem for elderlies, anybody over 60. And it's a common cause for people being admitted to old people's homes, or despite the fact that such a troubling symptom, less than 50% of people will seek medical attention. Patients are often very embarrassed. They don't like to tell even it's only the fact that they're shunned because they smell, because they are incontinent, or very often they have to wear pads or diapers. There is a lot of misunderstanding and misconception about incontinence. Many people, at least women, seem to feel it's a part of growing up. Having had 2 or 3 children, it's common to have incontinence. And even older people with prostatic enlargement seem to think that it's a little bit of incontinence here and there is quite all right. It's part of growing old. But that's not actually the fact. Incontinence is a complaint, can be addressed and should be addressed. If you leave it unattended, incontinence and medical complications can occur. That's sepsis, urosepsis, infection in the urine, rashes, pressure sores, and sometimes because of the urgency of going to the loo, falls, There's also a lot of psychological complication with low self-esteem, isolation, because you think or you know that there's a smell about you that you may not want to socialize, and it's the commonest cause for people being admitted to sort of old people's homes because they cannot function well in society. Who is at risk? Anybody who is over 50. Women are affected about twice as more commonly than men. It, the general conditions are obesity and diabetes. Anybody, male and female, if you are obese and diabetic, you're more likelihood to have incontinence for various causes. There is a condition known as GSM, that is genitourinary complaints of menopause, genitourinary symptoms of menopause. That's common with all women after menopause. Of course, as everybody knows that as age advances, you have to, your hair grays, the cataracts appear, and the prostate appears. No one escapes that. So the enlarged prostate is often a cause of varying degrees of incontinence. But more serious conditions are neurological conditions and previous genitourinary surgery that may have been had. One large number of conditions is drugs that you might have been given. Now, we all take a whole battery of drugs, and many of these act on the urinary tract, and some of these can give rise to incontinence, frequency, urgency. So it's very, very important when you go to the urologist or to any doctor with your complaint to have your whole list of drugs that you are taking written down so you can go through them and have a quick study of that. Now, I'm just going to give you a basic idea of how the bladder functions. Yeah, the brain is above all, everything, the brain controls everything. But the bladder goes through two phases. One is the filling phase and storage. At that time, as your urine collects in your bladder, the muscle of the bladder relaxes. It does not contract at all. You're not aware of your bladder at all. And the sphincter, that is the area of the sphincter, which is this area, the muscles that control the outlet, they contract, tonic contraction. So this is the phase that you are in right now as you're listening to this webinar. When you feel like passing, then at this stage, your bladder will contract. You'll get a signal, your brain that gets to know, oh, I think I need to go. And the brain gives a signal, and the bladder muscle contracts. The bladder muscle contracts, and this muscle relaxes completely. So the urine comes out. At the end of voiding, the urine is all, the external sphincter, that is the sphincter that controls the passage of urine, contracts immediately, and you don't leak any urine at all. The last drop of urine is squeezed out, and following that, you don't lose any urine at all. Unfortunately, in the males, there's a little bit of urine in your bulbar urethra, that is urine in the penis, and therefore it's common practice for males to shake out the last few drops. And once you've done that, there is no further, no urine will come into your pants or underpants. So that's how normal urination does occur. There are four absolutely separate and different kind of conditions where man or woman can be embarrassed by incontinence. One, which is here, and that is overflow. Now, this happens because of anything obstructing the bladder slowly. Whatever, take for example, enlarged prostate. The enlarged prostate will cause obstruction to the bladder. Generally, it's very insidious. The obstruction goes on for many years. And if unattended, if the patient does not go to the doctor, seek any attention, he says, oh, I'm passing urine frequently, but that's all right. Then comes the stage when his bladder is quite full, and then he keeps on leaking. So it's very common to find that somebody says, oh, my dad was all right all the time. He was fine, absolutely all right, passing urine, getting up 3 times at night. But now he's passing urine all the time. Every 10 minutes, he's rushing to the loo, and all he passes is about 10 ml. So that means that his bladder is full, and the tank is full and is overflowing. So he's passing urine all the time. Okay, that's overflow incontinence, common with enlarged prostates in males. This is stress incontinence. Now, this is very common with younger people, younger ladies, see around about 40, 45, who've had at least 2 or 3 children. And because of having children, the support of the bladder is loosened, and they have not bothered to do exercises to bring that tone back again. As a result, they're perfectly well otherwise. They don't have frequency. They don't have to go to the loo very frequently. They're fine. But it's only when they laugh or they cough or they bend down to pick something that a small squirt of urine comes out, and that embarrasses them. Now, this is what we call genuine stress urinary incontinence. Very often, ladies with genuine stress urinary incontinence will also have this urge incontinence. Now, urge incontinence is quite different. This is a bladder muscle that is a little oversensitive. Normally, your bladder will remain quiet until your bladder collects about 200. Then it gives you the first signal, then about 250, and then you say, oh, now I've got to go. But these unfortunate ladies and men have urge incontinence. That means by the time the bladder is filled with about, say, 150, 200, they have to rush to the loo. And it's the rushing to the loo that is more important. It's the urgency. So the signal to the time they have to get to the loo in time is short. They cannot hold on for any length of time. That's urge incontinence, very embarrassing complaint, far more embarrassing than any of the other complaints that I've said. And lastly, there's functional. A lot of people will be incontinent because of functional reasons. I mean, old age causes a lot of what should I say, bradykinesia, that is slow movements. You're arthritic, you cannot get, so by the time you get to the loo, you tend to lose some urine. Or there may be other conditions like Parkinsonism, slow gait, or you may be incarcerated in bed and you have to nobody to attend to you. So all these conditions that are called functional, you may lose urine without actually wanting to. So this is the diagram that gives you an idea. Stress urinary incontinence is due to abdominal pressure under stress. That means when you cough, laugh, sneeze, or bend down to pick something, the pelvic floor muscles, which normally hold the urine back, relax, and the urine spurts out. In between those episodes, when you leak, you're fine. There's no urgency. You're not running to the loo. Otherwise, you're quite fine. Okay. Urge incontinence is ladies or men who find they have to go very frequently, and not only just frequently, urgently. So they cannot even, they might have to stop you in conversation mid-sentence, say, sorry, I think I better go to the loo, and rush there. And very commonly, they're banging on bathroom doors to get the other person out because they need to go. That's urge incontinence. Overflow incontinence, I already told you, that's just the chronic and slow blockage of the outlet, which gives rise to a large bladder, which is now uh, overflowing. It's already full and overflowing. Neurological incontinence is something quite special. Variety of neurological causes can cause incontinence. Common among these are Parkinsonism and strokes. So after a stroke, there's usually, by stroke, I mean a cerebral stroke, a stroke of the brain stroke. After that, there's some degree of urinary problem because the brain controls, as I told you earlier, the brain controls all urinary activity. And because of that dissociation, your urine incontinence can be there. Second thing is Parkinsonism, where that part of the brain which is responsible for suppressing the micturition urge. Like, for example, now I'm talking to you, I might feel like going for a leak, but I just suppress that urge and say, not now. I've talked to these wonderful people. I'll go half an hour later. And that ability is lost in Parkinsonism. Of course, in a condition where dementia of all causes, whether it's Alzheimer's or whatever, then there is very little ability to control the urine and you leak out the urine. Right. Let's talk about this condition, which is the most common type in elderly, sudden strong urge to void caused by an involuntary detrusor. Detrusor is a bladder muscle contraction, not making to the bathroom on time. Okay. This is stress incontinence, loss of urine when you, with raise of intra-abdominal pressure, weakening of tissues around the external sphincter, overflow incontinence, as I told you, for men with prostates, etc., or diabetic nephropathy as well, neuropathy. Okay. Functional is what we call loss of urine unrelated to urinary tract disorders, but usually like degenerative joint disease, cognitive impairment like dementia, and medications, etc. This is a kind of algorithm that we often have for when you enter a geriatric ward. We say always, men and women who are incontinent, look at these conditions. It's an anagram that says diapers badly spelled with two P's instead of one. Delirium, when the patient is not quite there, he will leak urine. Infection, he will leak urine. Atrophic vaginitis, old ladies with contracted vaginas because of long-standing hypoestrogenism because of menopause, pharmaceutical agents, psychological factors, excessive urine output, compulsive water drinkers, restricted mobility where they can't get out of bed, and stool impaction. That is when severe constipation and hard stools in the rectum often presents first with incontinence. They don't even tell you that they haven't actually opened their bowels for 1 week. Right. How do we diagnose this? Generally speaking, I find that I can make out what is the cause of a person's incontinence in just talking to them. It's all in the story. If you listen carefully to the story in detail, then you generally have your answer almost 80% of the time. First thing you need to know is diabetes, neurological conditions, infections, surgery in the past. Heart failure is a very important cause because heart failure means a lot of fluid is left in swollen parts of the body. And then at night, all that is mobilized and they have to get up very frequently at night, and sometimes they are incontinent of the urine at night. And has nothing to do with the urinary tract. It's entirely a cardiac condition. How did it come about? Did it come about over years? Has it come about recently? How frequently do they have to do they wet themselves, and the amount they're wetting themselves? I find that it's a very, very important thing that you take a list of all the medication. That's first and most important. Drugs that the patient is taking. It's now very, very common to have patients who are on psychotropic drugs, that is, drugs for depression, anxiety, and a variety of psychiatric ailments. And they all have a bearing on urinary continence and dysfunction. So the medical history is very, very important. Sexual history is also very, very important because you need to know about dyspareunia on women who say they can't have any sex anymore because it's quite painful, it's not comfortable. And so that is a very important bit of sexual history. Voiding, the most important thing you can do for the doctor before you go and see him is have a diary for the last 2 to 7 days. In that, what you do is you take an account of roughly of how much water you've been drinking and the number of visits to the loo, including the amount of urine you passed. And if there were any episodes where you actually wet yourself, you write it down. So that kind of diary or history of how you'll be will give you the doctor who's treating you an excellent idea. If you're armed with this information, generally I say that you can diagnose what's going on in about 80% of the times. The next thing is to examine him, as I said earlier, overflow and empty. So I think the most important thing at this stage is to see if the patient has a full bladder or an empty bladder. Is he incontinent because his bladder is full? Or is he incontinent because he can't hold any urine and his bladder empty? That's the first order of business. After that, you've got to generally do an examination of his fitness, obesity, diabetes. As I said, is the bladder full or empty? And then you have to examine the rectum, very important. You know that you come to a urologist or to any doctor and you have to have your rectum examined. And ladies will have to have their vagina examined. The rectum, because of the sphincter control, how good is the sphincter control of the rectum? Because the rectal sphincter is shared with the urinary sphincter. And also, are stools impacted? Large stools impacted will cause incontinence. How large is the prostate? On vaginal examination, we generally look at general mucosal health. With menopause, the vagina tends to become drier, and as it becomes drier, it contracts. And with that contraction, the urethral opening does not stenose, but becomes sort of rigid. It becomes a pipe stem urethra rather than a soft, pliable urethra. And these kind of people don't empty their bladders too well. As a result, they leak urine in between. Of course, at the same time, when you're examining this lady's introitus, you ask them to cough, and on the table they will leak out urine. Then that's a test for stress urinary incontinence, and you can reposition the urethra and ask them to cough again, and the cough does not cause incontinence. This is a proof that the incontinence is entirely because of stress urinary weakness of the pelvic floor. Investigations may be necessary. You have to see if there's no infection, general assessment of kidney function, and ultrasound to see if the patient is having a full bladder after attempting them. Is the patient able to empty the bladder, or is part of the urine left behind inside? A vaginal ultrasound in women may be required. The last is urodynamic assessment, generally reserved for neurological patients or for patients in whom the diagnosis is a bit problematic. One doesn't seem to get to the true nature of what's happening. Then a urodynamic assessment will be very, very helpful. I find that urodynamic assessment, when it needs to be done, is best done by video urodynamics, where you can see exactly when the urine incontinence occurs and how it occurs. How do we treat urinary incontinence? There are three general ways of treating incontinence. One is behavioral, and you address their behavioral sort of underlying conditions, medical by giving drugs, and finally surgical in some patients. So what is the behavioral? Now, women who have stress urinary incontinence, as a matter of fact, after every pregnancy, every woman should learn Kegel's exercises and learning how to increase the tone of the pelvic floor. The Kegel's exercises are a very inherent part of improving your pelvic floor musculature. It's very poorly understood. Most people don't understand how Kegel exercise to be done, but we'll talk about that later. There are other ways of treating women who have urgency and urge incontinence. You can do biofeedback. Now, this is a condition where we connect this lady to a computer, and then you make out when she's getting the urge. You can make out from the sphincteric activity when she's getting the urge, and we ask her to suppress the urge. I mean, try not, and there's a visual representation on the computer, and you can suppress the urge. It's not easily available in all centers in Bombay or India, but bladder training is easily available anywhere. In bladder training, all you do is every time you get the urge first, you tend to prolong it as much as possible. You'll have drugs to help you out in that, and with the help of drugs and bladder training, you can get rid of a large degree of overactivity of the bladder. Women or men who tend to retain urine are told to have timed voiding so that they usually forget, they don't want to go. So you remind them that they have to go, timed or prompted voiding. Double voiding for people who don't empty their bladders completely on the first void, but have no other complaint. So you make them pee and then say, just move around for 10 minutes, come back and pee again. And you find that you are able to pee a significant amount. So that's very, very important. Sorry, I have a cold. And the last thing, which is very, very important in behavioral therapy, is avoid tea, coffee, sodas are all enemies of your bladder. So you would be advised to reduce the amount of tea intake, coffee intake, and cokes or other sodas, and even fruit juices. They all make your bladder a little overactive, and it's best to limit these beverages to a minimum. Now, a little bit in detail about PME, or that is pelvic floor exercises. It's often performed completely incorrectly, and often even physiotherapists don't seem to have any idea of how pelvic floor exercises are to be done. It's very, very simple for a man or a woman. All you do is you go to the loo, pass urine, and somewhere in the middle of your urinary stream, stop your urinary stream. Then restart the stream, stop it again, and have a mental connection, your sort of uh, mind-body connection or brain-muscle connection that tells you what was the muscle that you contracted in order to stop the urine. Now you contract that same muscle without having any connection with your urine passage. So you're sitting down on your sofa watching television. You stop that muscle and keep it contracted for about 10 seconds, and then relax it. And do it about 30 to 40 times. Do it about 3, 4, 5, 6 times, as many times as you can. Once you know how to do this, you can do it while sitting, sleeping, even walking. You can do the contraction of you can do your Kegels exercise even while walking, because you know what muscle you are contracting. You have to contract it tonically. There are the other exercises, but I find that this is the most important exercise, and unfortunately, very few physiotherapists teach this correctly. For a man, he can make out whether he's contracting the right muscle by putting his hand under the scrotum and feeling the muscle there. And when he tightens the muscle, he can feel it contracting. If you're standing in front of a mirror and you're contracting it, you will find that the penis moves slightly upwards. And that is indication to the man that he's doing a proper Kegel exercise. For the women, it's a bit difficult. You can't really make out how you're doing it. But you should be able to contract that, and as if you are stopping the urinary stream. There are other things, other alternatives like holding weights, vaginal weights. And this was often in physiotherapy departments. They will give you a vaginal weight to hold in your vagina up to 15 minutes twice a day. And that helps to contract your pelvic floor. Biofeedback, I told you already, is not very, very simple, and only specialized departments will have this. I already told you, consciously delay the desire to void. The bladder is entirely under the control of the mind. And that's, we find this difficult to believe. Then when you were a young lad, difficult to find out when you were a young lad. But anyways, when you were a young lad and going for the examination, or you're sitting for a test, then you found that you needed to go to the loo before you entered the examination hall. And just when the bell went off and you wanted to enter the examination hall, once again you felt like going to the loo. And you said, I've been just now. It's your mind playing tricks on your bladder. The moment you sit down and start writing your paper, that desire to pass urine is gone for 1 hour or whatever time it takes for you to write that paper. So the mind plays tricks on the bladder, and you should be aware of that. So consciously delaying the desire to void by inhibiting the urge to void is an important thing that helps building up your resistance to overactive bladder. Void, according to a timetable, about 12% of women regain continence with a mixture of pelvic floor exercises and bladder training. I already told you about timed voiding. Now, drugs. What can we do with drugs? Well, we have a drug for almost everything. Let's talk about the bladder, the outlet, that is your sphincter, and the vagina. And these three things I will tell you. First, and on the vagina, I would also tell you the prostate. That's another thing. Okay, so the bladder, if your bladder is overactive, then if the bladder is overactive, you have drugs that quieten the bladder. Your doctor may have given you mirabegron or Mirago or Mira or something of that, or solifenacin or ditropan. These are drugs that relax the bladder. They give you symptomatic relief. It's like taking something to dry up your nose when you have a cold. But the cold is caused by a virus, nothing will help that, but you can take something to help you out. So these drugs help out the contraction, reduce it, but they must be addressed with additional behavioral therapy and exercises. If your bladder is underactive, you can give something to help it contract. The drug is called bethanechol, generally not very useful. it doesn't seem to work all that effectively. Now, the outlet, if the outlet is overactive, like the prostate, the bladder outlet is overactive because the prostate is there contracting and preventing the urine from emptying, then you give muscles to relax the prostatic musculature, and those drugs are commonly used by almost all senior citizens. They are either a combination of tamsulosin, silodosin, or alfuzosin. These are three commonest drugs that we use for an enlarged prostate. Not every enlarged prostate needs surgery. As a matter of fact, fewer people need surgery than one you would expect. Almost about not more than about 30% of people with enlarged prostate need surgery. The 70% are very effectively controlled by medication. If the sphincter control is underactive, like in a stress urinary incontinence, low degrees of stress urinary incontinence, you can use a drug called duloxetine, along with pelvic floor muscle exercises. If all this doesn't work, then surgery has to be resorted to. Women who have problems with GSM, that is genitourinary symptoms of menopause, who have vaginal tissue which is dried up because of hypoestrogenism, they can use local estrogen creams. There is some concern about estrogen being absorbed and therefore may cause a problem with genitourinary malignancies in women or breast cancers. But this is local and doesn't get absorbed to any great extent. Anyways, you have a plan. You don't keep them on these drugs forever. You give them in a intensity reducing regime and then stop it altogether. But estrogen creams do help in controlling this dryness of the vagina. Finally, for those who are not helped by all this, surgery needs to be resorted to. Surgery for stress urinary incontinence is perhaps the most gratifying, because here's this lady who leaks out urine every now and then. All you have to do is replace and reposition the hammock. The bladder is like an organ that is sitting on a hammock, and the hammock has become loose with pregnancies, and so all you do is you tighten the hammock, either by the use of a synthetic sling, which is a plastic sling, very high quality plastic sling, or using the patient's own tissues, like the fascia from the fascia lata in the thigh, or the abdominal musculature. Generally, the synthetic slings are most preferred because it's a very simple procedure. There are some concerns in some women that the synthetic slings can cause problems, especially with dyspareunia, or that is difficult sexual intercourse afterwards. Rarely, not very, very common. And sometimes that the swing and these slings tend to erode. These are all rare complications. They've done properly. The slings do very, very well. Surgery for prostatic problems, obviously you give prostatic patients medication and they do very well. There comes a time when the medications have a losing battle, and despite the medication, understand this, that the prostate does not give us any concern whatsoever in itself, other than being the site of a cancer. And so the first time when you meet a doctor with your prostatic problem, he does an examination of your rectum, he asks for a PSA, and once he's convinced that you don't have a cancer, then he deals with your prostatic problems on a quality of life condition. So you give them drugs and you feel much better. But there comes a time when, despite the drugs, etc., you don't empty your bladder carefully and properly. Your bladder is getting thickened because of continuous obstruction, and you need some treatment, surgical treatment, and that's removal of the prostate. It's a simple procedure done endoscopically in most cases. If the bladder capacities become very, very small, you can augment the bladder. And this is incontinence caused by a tiny bladder for women who have what you call interstitial cystitis, and they need to augment their bladder. Or surgery to, if the bladder is, as I told you, if you have retention overflow, urine doesn't come out, you can give drugs, but they don't seem to work. You may need to get them to catheterize themselves intermittently to empty their bladders. Finally, there are neurological conditions that cause bladder problems, and they have some specialized neurological stimulations of the bladder that are available. I think I have waxed eloquently for too long, and I will finish at this point. So thank you very much, Pradyuman.
Thank you very much, Doctor. Thank you very much. I think your presentation was very detailed and had almost everything in it. Can I request you to close the presentation?
Yeah, sure.
Stop the screen. Yeah, great. Thank you.
Okay.
Yeah, so we have, thank you for the presentation. I think, you know, very detailed. And as always, I'm going to put in uh, links to some of the, a cover story which Dr. Chibber had written and two of the webinars. So those of you who would like to see what he has said in the past on prostate, especially, you could do that. Doctor, we have some time, so can we ask?
Yes, certainly. If there are any questions, I'll answer them.
Yeah. So we have one question from somebody who's 67. He says, I have to three to four times for urination. My question is, how do I control the prostate problem in future? He's 67.
But yes, obviously he's not incontinent. He's just going frequently to the urine passage, and that is because he has a prostate which is obstructing the outflow of urine. He needs to take medication, even if he is tolerant of it. Many senior citizens seem to say, oh, it's part of growing old. First, I used to get up only once at night. Now I get up twice at night. Now I get up 3 times a night. Oh, it's kuch nahi hai. Wo to sabko hota hai. That's not true, because as your bladder keeps contracting to expel your urine and overcome the obstruction, caused by the prostate, the bladder muscle becomes thick. And unlike our external muscles, you lift weights and you get biceps, you look good and you are stronger. The bladder muscle does not need to get thicker or stronger. As it gets thicker, it gets weaker. So that's what we are worried about. So if you have an enlarged prostate, you start on medication earlier rather than late. And so that will preserve your bladder for the future. Because once your bladder gets fired, even after prostate surgery, people don't do well. And that's one of the reasons why so many people say, अरे मेरे मामा ने मेरे काका ने ऑपरेशन कराया prostate का, वो तो उसको he's not doing all that well. The reason why mama and kaka are not doing well is because they went too late. They did not go earlier, and they were not assessed for this prostatic problem. Just because it's a chronic problem doesn't mean you have to be assessed. You have to be assessed for two reasons. One, to make sure you don't have a cancer, and two, to make sure that you're not ruining your bladder health. Because ruining your bladder health will have effect on what happens later. Is that clear? Very clear to the gentleman?
Yeah, absolutely clear. We have another question from a 73-year-old male. He says, what precautions should he take to prevent a UTI?
No precautions. UTIs in males occur because the bladder is not emptying and you have residual urine. So my answer to this question, the same as the answer to the previous question. You have to do a sonography or other tests to see how effectively you're emptying your bladder. If you're not emptying your bladder, you have to take medications to help you empty the bladder because of your prostate obstruction. If despite all that, you're still not emptying your bladder and you get repeated infections, it means your prostate needs surgical correction. Not very common. If you take the drugs, you do reasonably, emptying improves and you will not get these infections.
Right, thank you. We have a question from, so is it a good practice to avoid diuretic medicines for edema, swollen legs when the patient has bladder issues?
Diuretic medicine for edema has to be done because you have edema. Because of that, you will pass urine. Because the edema usually gets mobilized in the evenings or night, you will have to get up frequently to pass the urine. And that's, as I told you in my presentation, that this is incontinence or frequency not associated with the bladder. It's nothing to do with the bladder. It's bladder issues mean there's no bladder issue as such. The issue is that all that urine, all that fluid which is lying in your body because your heart is not pumping adequately, which needs to come out, has to come out through the urine. So this is perfectly acceptable. And you'll have to, until you're dried up, you'll have to take diuretics.
Right. We have a question which asks, which method is more effective for incontinence, Kegel exercise or posterior tibial nerve stimulation?
They're completely different. Kegel exercises for musculature. And this tibial nerve stimulation, it's known that if you stimulate the tibial nerve or the peroneal nerve, that your detrusor relaxes. Detrusor is the bladder muscle. So tibial nerve stimulation is used for urgency, whereas Kegel's exercises are used for women who can't early stress urinary incontinence. Like if you've had a baby and after that you're finding you're having this occasional escape of urine when you laugh or cough, then you can start a plan of Kegel exercises and hopefully that will disappear and you'll never need any kind of surgery at all.
Right.
So there are two different things. Tibial nerve stimulation for overactive bladder and Kegel exercises for the outlet being weak because of muscles being stretched by pregnancies.
We have another question which says, is continued use of sildosin, does it affect by way of reverse ejaculation or painful ejaculation? And
yes.
how can it
Now,
be?
of all the drugs that are used in enlarged prostate, there's sildosin and there is tamsulosin. Both these drugs are very, very effective inhibitors of ejaculation. So everybody, I mean, I generally use these drugs only with the consent of the patient, letting him know that he will not ejaculate. He'll have dry ejaculates. Does not affect the erection, does not affect orgasm, but the ejaculation will be dry. In the sense, he will not produce any ejaculate. There is a drug called alfuzosin that is less likely to cause retrograde ejaculation. So if you are a younger person, say in the 60s, who has this prostatic problem, I generally use alfuzosin and not sildosin or tamsulosin.
Right. We have a question which asks, Doctor, does the enlarged prostate turn cancerous with age, and is there a way to know that it has turned malignant?
It's nothing to do with the enlarged prostate. The zone of the prostate that turns cancerous is in the peripheral part. Imagine that your prostate is a little apple. It's the skin or the lining that turns cancerous. And the fluffy part which is inside, which is the part which becomes benign. So no, anybody, even with a non-enlarged prostate, can have a cancer. And enlargement of the prostate does not predispose to cancer. So just because you have an enlarged prostate, you have the same risk as anybody else of getting a cancer prostate. You have to, after the age of 60, I would say even 50, you have to visit a urologist once in at least 2 years if you have no history, and every year if you have a history. By history, I mean if you have a kaka, mama who has cancer of the prostate, not mama, kaka is mainly, or a father who had, say, a prostate, then I think it would be advisable to visit a urologist earlier. A urologist does a PSA and puts a finger in the backside. These two tests will generally give us a reasonable conclusion whether you have any worries about a cancer prostate. Okay, that's an answer. So
yeah. We have a question from a 63-year-old. He says, minor BP, no diabetes. He has prostate of 24 cc with eco texture. Pre-void volume is 400 cc. Post-void, it's 250 cc. No structure as per test. He has an inguinal hernia of 22 mm size on right side. His question is, does he need to meet a urologist? He's 63.
most definitely, yes. Most definitely. I'll tell you why. Because you are not emptying your bladder effectively, which means, as I was telling you earlier in my presentation, the prostate does not concern us, but its effect on your bladder does. So because of your prostatic obstruction, over a period of time, your bladder has now become weaker and is not expelling your urine. If you allow this to continue without any treatment, you will do yourself harm. So you need to meet a urologist. He may give you medication in the first instance, or he may, depending on requirement, he may even advise surgery. Already you can make out with the fact that you have an inguinal hernia that you're probably unknown to yourself, putting a little bit of pressure when you pass urine. You need to see a urologist.
Two more questions. One is from a 76-year-old male who says, my urologist prescribed Euroflow test and found flow rate low. He told me that full evacuation is not happening. I'm put on Silodicin 8 mg per night. How long should I continue to take this tablet? I have started Kegel exercise as well.
Kegel exercise will not help a prostatic obstruction problem. You can do it, and it's good exercises. Like no exercise is bad. So all exercises are good, but it's not going to help your problem in particular. You have an enlarged, I'm sorry, what did he say? He has a enlarged prostate. And what was his question saying? Give me again.
Sorry, 1 second. I just turned it off. My urologist has prescribed Euroflow test and found flow rate low, told me full evacuation is not happening.
Yes,
I'm put on Silodicin. How long should I continue to take this tablet?
yes. Now the question about Silodocin. Silodocin or tamsulosin or alfuzosin, these are the three common drugs for prostatic obstruction, last only for 24 hours. The obvious answer is you have to take it forever for it to be effective. You cannot stop it. You have to take it until such time as, despite your Silodocin or your tamsulosin or your alfuzosin, you are not getting relief. By relief, I mean your stream isn't improving, your post-void residue is not improving, then surgery has to be considered. So the answer to that is Silodocin is for life until such time as, despite the Silodocin, you will need surgery. Okay?
We have a question from someone who's not mentioned his age, but he says he cannot hold his urine for even 1 minute. I tend to wet my pants. My sonography has come clear of any prostate issues. I was told that my bladder does not empty entirely, but 35 cc's remain.
That's when you have probably, your bladder is reasonably empty. 35 cc is not a large amount, but you're going frequently, which means your bladder is overactive. I would have your prostate examined. If it's sizable, then you would take some drug for the prostate. In addition to that, you should take a drug to quieten your bladder, which is Mirago or Ditropan or one of the or solifenacin. These are drugs that will quieten your bladder. So you have to take a combination of a prostate drug, such as tamsulosin, silodocin, or alfuzosin, and Mirago or mirabegerin, which will quieten your bladder. You need a combination therapy.
Right. One last question is, does low or normal levels of PSA can also turn cancerous? Is that right?
PSA is not, the word PSA stands for prostate specific antigen, which means that it is specific to the prostate. It's not specific to cancer. So anything that causes the prostate to get irritated, shall we say, can push up the PSA. And a cancer can occur even at low levels of PSA. You're right. So that's why we have a combination of two things. We do a PSA and we put a finger up the backside. It's a combination of these two, because it's not it's uncommon, but not unknown, that even with a lower PSA, like 2, 3, or 4, that a cancer can exist. It is also important to correlate the PSA with the size of the prostate and also the history of the PSA. So if your PSA has been only 1 for years, and now suddenly it's jumped to 3.5 or 4, then that's a worrisome thing. Whereas 3.5 or 4 is still under normal. If your prostate is tiny, it's only 15 grams, and you have your PSA of 5, that's extremely worrisome. Whereas if your prostate is 70 grams and your PSA is 5, it's not worrisome, because you've got a huge prostate. You expect your PSA to be 5. You understand? So these are things which you have to do under correlation with the size of prostate, velocity, that is how your PSA has been behaving, and the clinical appearance of your prostate on the digital examination.
Thank you very much, Doctor, for a very detailed presentation and for responding to all the questions so patiently. And I know you have a bad cold, so do get well soon. To all of you here, we will be back once again next Saturday. Thank you very much to Dr. Chibber. The edited video and as well as the takeaways will be on our site on Monday evening, so you can access that. You can have a look at the presentation once again. Do remember that this session is advisory in nature. So in case you do have some issues concerning urinary issues, you must meet a doctor. Always, you can always consult Dr. Chibber himself at the various hospitals that he is with. Thank you once again, Dr. Chibber, for being here. And as always, they're available for us whenever we need you. Thank you very much.
Thank you, Pradyuman. Thank you. And thank you, the audience, for patiently listening to my dribble. Thank you.
Thank you.
Subscribe now and press the bell icon. Never miss an update.